what I'd like to do now is go ahead and move to our final panel for our policy summit. My name is Paul Conway. I serve as Vice President of the American Association of Kidney Patients. I'm a 48-year kidney patient and 28 years out on a kidney transplant.
Ready.
The theme of our event is Midpoint of the Decade of the Kidney, reprioritizing patient access across policy, regulatory, and payment decisions. And in this final panel, we're going to hear about why advancing kidney health requires challenging status quo practices. In the last panel, you heard one of our speakers talk about we need to break a few eggs. And you heard the president of AAKP say there's no problem with that with us. In fact, we like to make omelets all day. You may see an AAKP food truck soon on the National Mall in Washington, D.C. We're pleased that joining us today is Dr. Akhtar Ashfaq, Senior Vice President of Clinical Research, Development, Medical Affairs, and Pharmacological Vigilance at OPKO Pharmaceuticals. And I will say this, Dr. Akhtar has been a friend of AAKP for nearly 15 years. He has believed in the mission of this organization, and what he will tell you, I think, will be compelling about their efforts to try to bring the right medicine at the right time to patients. We'll also be joined by a very special friend of ours, again from George Washington University, one of our partner organizations for our global summit. Dr. Muriel Jagadeesan. He's a professor of medicine at the Division of Renal Diseases and Hypertension at George Washington University School of Medicine and Health Sciences. He's the chairman of the Transplant Medicine program and the medical director for the Kidney Pancreas Transplant program at GW. But first, what I'd like to do is turn your attention to the screens as we play a recorded presentation I was fortunate to do with Dr. Kevin Nguyen, who serves as the Assistant Professor of Medicine at the Department of Health, Law and Policy and Management. He's a faculty affiliate at Boston University Policy Lab, as well as a Senior Associate Editor of the Journal of Ambulatory Care Management at Boston University School of Medicine and Public Health. I had the opportunity to talk to him about the rise of Medicare Advantage and the number of kidney patients that are going into Medicare Advantage plans and what that actually means in terms of access to care. So why don't we go ahead and watch this, and then we'll come back to our panel. Thank you again, Professor Nguyen, for joining us. We're really pleased to have you with us, and we're very interested in your presentation on Medicare Advantage. Why don't you go ahead?
Thank you, Paul, and thank you to the American Association of Kidney Patients for the invitation to speak. I'm sorry I'm unable to be at the Policy Summit in person, but I appreciate the opportunities to share some brief remarks around the role of Medicare Advantage among people with kidney failure. So today I'll be presenting on work that was recently published in JAMA Network Open that evaluated changes in Medicare Advantage enrollment among beneficiaries with kidney failure in the first 2 years of the 21st Century Cures Act. Before I start, I just wanted to acknowledge my terrific co-authors at Brown University and the University of Washington, as well as funding from NIDDK. I've also provided a citation to the full paper if you have any interest in doing a deeper dive. Moving into background, as I'm sure many of us in the room are aware, Medicare is the primary insurer for individuals in the US aged 65 and older, as well as younger than 65 with disabilities. Importantly, particularly to this audience, Medicare provides health insurance coverage for most patients with kidney failure, with coverage beginning 91 days after initiating hemodialysis or at the time of enrolling in training for home-based dialysis. And while Medicare provides crucial coverage for more than 90% of Americans with kidney failure, there can be some substantial out-of-pocket costs in the form of premiums and deductibles. Now, Medicare can be offered in two ways: as traditional Medicare, sometimes called TM, or Medicare Advantage, sometimes referred to as MA. Broadly, traditional Medicare is a fee-for-service health insurance coverage that's offered by the federal government, and you can generally seek care from any provider that you'd like. MA, or Medicare Advantage, is a health plan offered by a private company like a United Healthcare or Humana, and enrollment has grown tremendously in the general Medicare population over several decades. MA can provide additional benefits not offered in TM, but they also develop provider networks. In addition, there may be lower out-of-pocket costs in the form of premiums or cost sharing. So there are these different trade-offs and considerations when thinking about what type of plan might meet your needs as a kidney failure patient. Beginning in January 1st of 2021, via the 21st Century Cures Act, Medicare beneficiaries with kidney failure were permitted to enroll in MA plans for the first time. Prior, they were only enrolled in MA plans under specific circumstances, such as being grandfathered into an MA plan upon developing incident kidney failure. And so there were very few estimates of the policy's impact on enrollment choices by individuals with kidney failure and disenrollment from TM to MA. So we sought to fill some of these gaps. More specifically, in our study, we had three main objectives. First, we wanted to examine national changes in MA enrollment among Medicare beneficiaries with kidney failure. Second, we wanted to compare the characteristics of those who stayed in traditional Medicare to those who switched from traditional Medicare to Medicare Advantage. And third, among those folks who newly enrolled in MA in 2021 following the Cures Act, we wanted to assess who remained in their MA contract, who switched to MA contracts, and who switched back into traditional Medicare in the subsequent year, 2022. Moving on to the findings, in this graph, we show Medicare Advantage enrollment among Medicare beneficiaries with kidney failure. And so what you can see is that among patients with kidney failure, Medicare Advantage enrollment increased substantially in the first 2 years of the 21st Century Cures Act, with the largest jump in enrollment in that first year. We estimated that MA enrollment increased from about 25% in January 2020 to 43% in December 2022, which is a relative increase of 72%. We also stratified our findings by race and ethnicity, and as you can see here, there were increases in MA enrollment across beneficiaries with kidney failure across races and ethnicities. However, the largest relative increases were among American Indian Alaskan Native beneficiaries, Black beneficiaries, and Hispanic beneficiaries. By the end of our study period, as you can see on the right, the highest rates of MA enrollment were among Black and Hispanic enrollees. In our assessment of who switched from traditional Medicare to Medicare Advantage, what we found was among beneficiaries with kidney failure who stayed in traditional Medicare, those who switched to Medicare Advantage were more likely to be younger, Black, and have at least 1 month of dual Medicaid insurance coverage. In our assessment of how enrollment changed in that second year of the Cures Act among those who had newly enrolled in an MA plan in 2021, we found that most, about 70%, remained in that exact same MA contract. However, about 7.9% switched back to traditional Medicare, and 22% switched to a different MA contract, which I'll note is slightly larger in magnitude when compared to estimates among the general Medicare population. And then lastly, we assessed how MA contract characteristics changed between 2021 and 2022 among beneficiaries with kidney failure who were enrolled in MA. Compared to MA enrollees with kidney failure in 2021, those in 2022 were more likely to be in a plan with a higher star rating, a plan with lower premiums, and a plan owned by United Health Group. What I would like to leave you with is a couple implications for policy and practice. First of all, MA enrollment is increasing substantially among the kidney failure population, and the increases actually surpassed CMS's initial projections, which were about a 30% relative increase in 2021. We also found in this study that Black beneficiaries who enrolled in MA in 2021 had substantially higher rates of switching compared to other races, which could suggest that MA plans might not be meeting the needs of Black beneficiaries with kidney failure. More broadly, I think one of the takeaways of this work is that as MA enrollment will continue to increase, it will be crucial to monitor the adequacy of dialysis facility networks in MA contracts and subsequently assess health outcomes among those who switched from traditional Medicare to Medicare Advantage. I thank you for your time and for your attention to this work, and please feel free to reach out via email if you have any questions about this study or my presentation. Thank you.
Thank you very much, Professor Nguyen, and we'll make certain that your contact information is made available to those who are watching online and who are in the National Press Club with us today. A couple of quick questions for you. One of the founding principles of AAKP is patient care choice, in the ability of patients to exercise their decision-making rights within healthcare plans and to pick therapies that they and their doctors feel are best for them. And so it's interesting, your data shows patients exercising their care choice each year when there's open enrollment. But within the plans themselves, any observations that you have about the exercise of choice among patients?
Really good question. And I think broadly, there's a lot of variation across different plans. And what I'll also note is that, as patients are considering their choices in terms of what type of plan to enroll in, whether it's traditional Medicare or Medicare Advantage, there are a lot of different considerations, whether that's out of pocket costs in the form of premiums and deductibles, whether that's choice of dialysis facility or you know, having the option of other benefits that might be offered in Medicare Advantage that might not be offered in traditional Medicare. So a lot of these different questions are part of that calculus in how you pick what type of plan to enroll in.
Okay. And then another question for you. We refer to this decade, 2020 to 2030, at AAKP as the decade of the kidney. And we're at the midpoint, part of the theme for this policy summit. And so, one of the other questions that I had for you is in general, in your research, and obviously with your co authors, many of whom are quite well seasoned in the field of kidney care, any observations that you had in terms of patients' access to innovations? Is it a patchwork quilt type of thing, depending on the plan that they're involved in, or do you see a uniform set of benefits for most kidney patients? What do you think is driving some of the switches, especially among African Americans?
Yeah, it's a really good question, and we weren't able to disentangle the mechanisms in our study. But there are a lot of different reasons why any beneficiary might switch contracts. What we did find was among those who stayed in Medicare Advantage but ultimately switched contracts was that there were switches toward higher quality plans and plans with lower premiums. So that could suggest that consumers and patients are becoming more attuned to picking the type of plan that better suits their need after that first year of initial enrollment in Medicare Advantage. But I think it more broadly warrants further exploration.
Okay. And then a last question for you. At AAKP, we don't think of ourselves as patients, we think of ourselves as patient consumers. And this is vitally important when you think about our ability, again, to make different choices, but also our sensitivity to the fact that kidney care costs a tremendous amount of money. It's a tremendous burden in terms of your life, your work, your time, but it's also a tremendous burden to the American taxpayer. And so, my question for you is when you take a look at the true cost of kidney care downstream, cumulatively over many different years, what do you think your top line message would be to kidney patients and to taxpayers about MA plans and kidney disease? What types of cautions would you communicate to patients in terms of making choices and being informed? And for policy, what is the best deal for taxpayers to keep an eye on these plans and to see what the outcomes are and demand more accountability and more transparency on outcomes? What are some of your key conclusions?
I think your last point is spot on. I think there are, kidney care is very complex, and so it really is important that as Medicare Advantage enrollment continues to increase, which we're seeing both within the kidney population as well as just the broader Medicare population, we need to make sure that the way in which these plans are designed really meet the needs of patients, whether that's in the form of costs, out-of-pocket costs and premiums, whether that's in the form of the benefits, or the ways in which the provider networks and dialysis facility networks are designed. There are a lot of considerations from a health system perspective, like healthcare delivery system perspective, that we need to consider. And from the patient consumer perspective, I think it will be important to continue monitoring how enrollment in Medicare Advantage, particularly for folks who might have switched from traditional Medicare, might impact health outcomes.
Okay, I appreciate it. And thank you so much for joining us from Boston University. You will not be a stranger to our efforts to educate folks on policy, especially policymakers, policy influencers, patients, and taxpayers. This has been a fast and very well detailed layout of where we stand on MA plans. And so I'd like to thank you very much on behalf of AAKP for joining us.
Thank you.
So, over the past several sessions, what we've heard here at the Policy Summit is the very complex environment for how companies that are leading the pack in trying to bring new innovations to kidney patients have to manage a bundled payment system by CMS, and how patient consumers are also being buffeted by the different winds of traditional Medicare and the marketing and recruitment plans of Medical Advantage or Medicare Advantage. It's a complex environment. But the other thing that's happening in this field is you have medical professionals who are standing up and saying, wait a minute, in order to create the best outcomes for patients, we need to bring medicine back to the patient and center it on them. And that's why it's a real pleasure to have two outstanding doctors who never forget who the patient is and are very close to the patient populations because they continue to give care and they continue to provide great deep thoughts about how things could be different and better for patients. I'd like to turn to Dr. Akhtar Ashfaq, who has known us for a long time. He'll be speaking on the importance of delivering the right medicine at the right time to the right patient, but just as importantly, shaking up and challenging current medical practice to make certain that those therapies that are most important to individualized care are delivered to patients when they need them. Akhtar, go right ahead.
Thank you so much. Good afternoon, everyone. Thank you, Ed. Thank you, Paul. Thank you, Richard. Thank you, Diane, and everybody at American Association of Kidney Patients for your kind information. It's a privilege to join you today in this important forum, standing next to the American flag, a place where science meets advocacy and where we have the opportunity to shape the future of kidney care together. Let me begin by sharing a little bit about myself. I stand before you not only as a physician who has been involved in kidney care for the last 30 years, as somebody who has been involved in direct patient care for 15 years, as a drug developer, but most importantly, as a patient, and somebody who has a very strong family history of chronic kidney disease. So every single day I wake up, the reality of disease hits me every single day. And that's the reason I'm such a fierce and passionate advocate, not just for myself, not just for my family, but the millions of patients who rely on us to ensure they receive the best care possible, grounded both in evidence and compassion. It is from this vantage point as a doctor, a scientist, a patient, and an advocate that I speak to you today about the urgent need to challenge the status quo in how we manage chronic kidney disease and its complications, particularly in addressing secondary hyperparathyroidism, or SHPT, one of the most common complications of dialysis. We all agree CKD is complex, we heard that before, but too often the way we treat its complication is governed by outdated beliefs than by evolving science. The result, persistent gaps in care, delayed intervention, preventable harm. Today, I want to make a case for why advancing kidney health requires not only to rethink how we manage complications of chronic kidney disease, but also at a very high level, how we support innovation, ensure equitable access, and elevate patients' voice in this process. Outdated thinking, preventable harm. Let's start with science. For decades, conventional wisdom held that kidneys were the only relevant source of active vitamin D, 1,25-dihydroxyvitamin D, or calcitriol. As kidney function declined, the assumption was that the replacement with calcitriol or vitamin D analogs was the only path forward. But that wisdom is outdated. We know now that CYP27B1, the key enzyme that activates vitamin D, is also widely expressed outside the kidneys, including the parathyroid gland. This means that this extrarenal activation of vitamin D is not only possible, but also therapeutically actionable, even in advanced chronic kidney disease. And this is why and where Rayaldi or extended release calcifediol comes into play. Rayaldi bypasses the hepatic conversion step, delivers stable 25 vitamin D levels, and enables sustained extrarenal production of calcitriol without the spikes of calcium, phosphorus, FGF23 that come with direct active vitamin D hormone therapy. Review of data show that raising serum 25D to at least 50 nanograms or higher is essential for meaningful PTH reduction and disease control. But that level is difficult, if not impossible, to reach with conventional dietary nutritional vitamin D supplements like cholecalciferol or D3 or ergocalciferol D2, especially in overweight CKD patients where vitamin D is accumulated in the adipose tissue. Yet, despite this compelling evidence, many guidelines still recommend a target of 25 levels of 20 to 30 nanograms per ml, a range far too low to activate the extrarenal CYP27B1. Other guidelines don't even recommend a target at all. And active vitamin D hormone therapy is often introduced too early, despite the calcium burden, despite the risk of hypercalcemia, despite the risk of hyperphosphatemia, and raising FGF23. And more importantly, possible association with faster progression of chronic kidney disease. Why is this happening? Because clinical practice is often anchored in outdated guidance shaped not by today's science, but by yesterday's fears, including outdated concerns about vitamin D toxicity at high levels of 25D, which have not materialized in multiple studies done with Royalty. Even in the most vulnerable hemodialysis population, where 25D levels reached as high as 160 nanograms per ml over a 6-month period, there was no evidence of any hypercalcemia or hyperphosphatemia. It's time we update our paradigm. Science is clear. Raising serum 25D levels to greater than 50 nanograms per ml with Royalty can safely and effectively reduce elevated PTH across all stages of chronic kidney disease and may even show disease progression, even slow disease progression in non-dialysis CKD. Innovation without access is injustice. But here is the deeper issue. Even we have effective treatments, they don't always reach the patients, as we heard all day from this morning. Royalty is FDA approved since August of 2016. It has demonstrated safety and efficacy in multiple randomized clinical trials, and yet it remains underutilized, not because of any doubts about efficacy or reported harm, but because the system is biased against new therapies who don't have yet large-scale outcome studies behind them. Let's be honest, those outcomes trials, multi-center, long-term, and measuring hard endpoints like cardiovascular events, hospitalization, or mortality are increasingly expensive, hundreds of millions of dollars, several years to complete. For a small company like OPKO Health, the scale of investment is nearly impossible without external support. And in the meantime, what happens? Guidelines stay frozen, reimbursements are denied, clinicians hesitate, and who suffers? Patients. We have a therapy that can help, but until there is an outcome trial, it is treated as optional. That must not be acceptable. Let me ask you, how many more years of suboptimal care must patients endure while we wait for the perfect solution? Is it ethical to deny patients a safer, more physiologic option simply because it does not yet meet the arbitrary evidence threshold that was never applied to older, riskier therapies? This is not just a scientific problem, it is a health equity issue. So what I'm suggesting here is a call for a new model. If we are serious about transforming kidney care, we need a better model, one that recognizes mechanistic and biomarker-driven efficacy, not just long-term outcomes. Support smaller innovators through public-private funding, NIH-backed mechanisms to fund outcome studies, and allow regulated, conditional guideline adoption of novel therapies while outcome data is maturing, because patients should not have to wait a decade to access better care. We do it in oncology, we do it in rare diseases, we can and should do it in kidney care as well. My final thoughts on this issue, that's where I want to close this. The burden of CKD and its complications is growing. Science is evolving, the tools are here. What we don't have and what we are lacking is the courage and discipline to change and the mechanisms to support that change. We must stop thinking of innovation as a luxury, as has been mentioned by Dr. Nguyen. It is a necessity, because every day we delay better treatment is another day a patient progresses to dialysis or death. That is unnecessary. Another day a clinician has no choice but to prescribe a less effective or more harmful therapy. Another day our system fails the people it was designed to help. Let's challenge that. Let's demand more from our clinical practices, our guidelines, and our policy frameworks. And more importantly, and most importantly, let's do it for me, other patients, because we deserve nothing less. Thank you.
Doc, thank you very much. You used two words in your presentation that really ring a bells with AAKP and our 50-year history. You talked about justice and you talked about matters of ethics. We completely agree with you. Shaking up the establishment, challenging status quo, and challenging guidelines, and challenging models that do not focus on the patient and optimum health outcome and saving lives is exactly what we're in the business of doing, and it's exactly why we're doing this policy summit. We appreciate you, and we appreciate your courage in bringing these issues to the forefront. What I'd like to do now is move to Dr. Jagadeesan from George Washington University. And Dr. Jagadeesan is very similar in the regard that he challenges the status quo and asks why. Dr. Jagadeesan is an expert in transplant graft failure, and he sees a lot of patients, especially over the past 4 years with COVID. He has very particular views about wrapping around the care system around a kidney transplant patient to ensure long-term health and better outcomes so that patients don't have to get transplanted twice or 3 times. Dr. Jagadeesan, why don't you go right ahead? I think your thinking is very novel on this.
Thank you for the kind introduction, Paul. Distinguished guests, members of the Congress, members of the administration, dear colleagues, and my dear friends, and last but not least, my patients. My talk is going to be on a different note. It's not to do what happens before the transplant, although that's very important. It's going to be what happens after the transplant. And I'm going to start with a story. I always start with a story when I give talks to students. Several years ago, a patient came to me for getting listed for a kidney transplant. Fortunately for him, he had a living donor who was willing to donate the kidney. He was on dialysis for 5 years. He had a very successful transplant. It did very well. For the first year, he came meticulously to every post-transplant visit. His kidney function was fantastic. We thought he was the poster child for transplant. Then suddenly something happened. He fell off the grid. And the follow-ups did not happen. We could not get in touch with him. And he was lost to follow-up. Several months ago, he came to our ER. And he was in kidney failure. So I asked him what happened. He said he did not take his medications as he was instructed to. He could not afford it. He could not obtain it. A lot of reasons. But in short, he had a very bad rejection. And that rejection could not be treated. And he went back on dialysis. Now, he's back on dialysis with a sensitized kidney, which means he has got antibodies. He does not have a donor. He's going to wait for 6 or 7 years. It's the most heartbreaking thing for any transplant professional to see a patient lose a graft well before the graft needs to. I mean, it's got a lifetime, we know that, but 2 years, that's too short. So this is something we need to attend to. We all know transplant is the preferred choice. You ask any kidney patient on dialysis, they're going to tell you, we'd prefer a transplant. You ask a transplant patient, they don't want to go back on dialysis. So why is that? You look at the graph on the left, it gives you patient survival data with terms, compares dialysis and transplant. The bars, orange bars are patients on dialysis. The blue bars are addition of life years when they get a transplant. And across the y-axis is different age groups. Regardless of what age the patient belongs to, there is a survival advantage to transplantation. Of course, if you're younger, you live longer. That is natural. Look at the right-hand side. That's a graph which measures quality of life. Of course, we heard that quality of life needs to be modified, but even so, all the patient responses favor transplant. It's on the right-hand side. You don't even see a single response on the left-hand side, be it physical well-being, mental well-being, emotional well-being, productivity, so on and so forth. So in short, as someone mentioned earlier, it adds life to years, years to life. Now, I always show this slide for any talk. This is no exception. This is why it started about 70 plus years ago with a transplant at Peter Ben Brigham Hospital, which is now Mass General, of identical twins, a donor and recipient. The transplant was performed in 1954 by Dr. Joseph Murray, along with the nephrologist John Merrill. The photograph is on the top of the operating room, and the team is at the bottom. And then after that, the trials and tribulations of understanding the immune system, designing drugs, having a policy, a structured national policy on transplantation, formation of the UNOS, the transplant legislation for transplant, and on to now what we have, xenograft, the advances in molecular medicine, which has made this possible. This has been a long voyage, definitely a successful one. However, challenges remain. And these are the challenges I'm going to talk about. This is a little bit of a crowded slide. I'm going to spend some time on it. So let me run through the slide. If you look at the graph on the very top left, this is outcome data of patient and graft survival of both living and deceased donor. I'm going to take you from the top to the bottom, okay? And it compares various timelines from 2000 to 2025. If you look at the top graph, there's a bold line in blue and green, which depict living and deceased donor transplant. That is 1 year graft survival. Over the last 25 years, it was good. It's gotten even better. Go the next two lines in dotted lines in red and green. They show you the 1 year graft survival. That is how long the kidney lasts, not the patient. So it started somewhere close to the high 80s in 2000. Now it's over 90%. The next two lines in green and blue show 10-year patient survival. Now that has increased significantly from 2000 to 2025. It's beyond 80% now. Now look at the last two lines, dotted lines, which are both for deceased and living donor. This is long-term graft survival. It has gotten better, but still we lose a third of our grafts in 10 years. Look at it in other terms. If you transplant 10 patients, in 10 years you're going to lose 3 of them. That is simply unacceptable. That status quo has to change. So, despite improvement in graft survival, over the years, 30% of kidneys will fail in 10 years. And I'm going to show you a graph on the right, which shows that the number of transplants we do are not keeping pace with the demand. Again, look at the X down. There's a black line, if you notice. That's the number of transplants over the years. It's grown up. We do about 24,000 transplants a year, but not significantly as time over the last 25 years. If you look at the top line, that's wait-listed patients. That's how many patients are waiting to get a transplant, steadily growing up. You look at the big pink thing in between, that is the demand, that is the gap. We are not keeping pace with it. Obviously, whatever we have done so far ain't working, guys. We got to look at it from a different angle. We can increase the number of transplants by many methods, increase living donation, having more sensible policies of allocation so that discard rates are reduced. But we have to increase the longevity of the transplants. Now the average deceased donor transplant lasts for what, 14, 15 years? A living donor, 20 years plus. We need to go way beyond that. Now, transplant is not just the better option, but it's very cost effective. Now look at the graph on the left. Everybody knows this in the audience. That tells you the annualized cost of different modalities of dialysis and transplant. You can clearly see that transplants after the first couple of years is $15,000 per year, as compared to what somebody said, $100,000 for a dialysis patient. Straight away, you don't need to be an economist. It is cost effective. Look at the graph on the right. That tells you an even better story. That tells you the cumulative cost of both these modalities. At around 248 days, it breaks even. And then it just keeps on paying back to you. So if you look at the difference, there's a straight line, dialysis, every year. Transplants, after about a couple of years, it plateaus and grows slowly. Now, I did a calculation on this. And I looked at, let's say, the average dialysis patient is $100,000. The average for transplant annualized over a 10-year period comes to about $25,000. Make a difference of $75,000. multiply it, and make out the difference. Guess what the difference is over a 10-year period? Anybody? $7.5 billion. I actually redid the calculation 10 times because I wanted to be sure I was right. I did it in the old-fashioned way and also in a calculator. Put it in other terms. Even if you have a 10% reduction in the wait list, that's going to be how much? $750 million. A lot of change to, and we can invest this in healthcare and in ESRD and in transplant. So we have to increase the number of transplants. Another one of my favorite graphs. Guess what? When you ask people, what is, even the fellows who work with me, what are the common causes of patients entering the wait list? Sure, they'll tell you diabetes, they'll tell you high blood pressure. What they will fail to mention that retransplants is the third most common. Look at the pie chart, right? Blue is diabetes, about 35%. Next comes hypertension, a little bit less. 15% of the patients are relisting. When I was a fellow 25 years ago, having a second transplant, that was not very common. Then third, now fourth. We even see patients for the fourth transplant. That should not even happen. Now remember this, every year, 6,000 patients fail a transplant. A third of them enter dialysis. Now you can calculate from this what it does to the wait list. This is one of the reasons why the wait list keeps on increasing. Again, that's how these both are interacting. Increase the longevity of the transplant, you will reduce the wait list automatically. An interesting calculation. I was talking to Paul last night or several days ago, and I asked Paul, is there any data, if I were to increase longevity, what would it impact on the wait list? Paul said, not really. So I said, well, this is the age of AI. Let me use SRTR data and make some projections. So that's what it shows on the x-axis is just number of waitlist patients. On the y-axis, years in time. And what I said, I made some assumptions basing on existing SRDR data. Let's say we make no change. What happens? Your waitlist keeps on increasing and approaches 100,000. That's where we are today. This data is about 5 years old. Look at if we drop 12 months from that, we improve your longevity by an average of 12 months. We're just treading water, guys. It's still maintaining the same. Now, what if we drop 24 months? The improvement in the wait list is 25,000 patients. What if we make it 36 months, or it halves? Your wait list in 10 years drops to about 60,000 or so. Add to it the innovations in transplant, the xenografts, the better way of better immunosuppressants, the biomarkers using artificial intelligence, the advances in glomerular diseases. I am sure that in 10 years we can achieve less than 40,000 patients in the wait list, and at least a patient can get a transplant within 3 years. There are states where they wait for 8 or 9 years. That cannot happen. That status, we have to break that, okay? For long, we accepted it as a status quo. It's time to change that. One of the most common causes of losing a kidney next to dying with patient death with graft loss is the most common. The next most common is not taking the medication. It's a low-hanging fruit. It does not, I am a big fan of technology and all the advances. I'm a transplant nephrologist. I love immunology and xenografts. But this is very simple. If you take your medications, your kidneys are going to last longer. The reasons for adherence, there are many. It's a basket of reasons. Patients' side effects, not being able to afford it. Insurance is a nightmare. You know, I looked at some of the things in insurance. I'm a physician. I cannot fill the paperwork. I kid you not. I have no idea until one of my family members got sick and I was going through the insurance claims and stuff like that. I spent the whole of last year doing it, spending like hours every day. Not possible. I can tell you from practical experience what the difficulties are. So this is another very important. We need to spend resources, allocate resources, research, and funding to improve medication adherence. Now, does it work, all this stuff? I'm going to ask for money from all the, I'm saying that we need more resources, more money. Remember, and we had this important piece of legislative action, which sponsored by by AAKP and others, resulted in the lifetime immunosuppressive medications being free for Medicare patients at 80%. We had to pay the 20% copay. What happened after that? You can look at the graph. The extrapolations were $400 million, 10 years saved, just because the act was passed. Medication adherence improves, another $73 million add to the change. Quality of life gets better. So we know that these policies, if implemented, do work. So where do we go from now? How do we reimburse transplant? We need to change the way we do it. This is a pet peeve for all transplant nephrologists and professionals. You go to our meetings and go to a transplant nephrology group, this is what we talk about in the chat rooms and our WhatsApp group. Now, transplant is a very complex group of patients deserving of a collaborative, holistic-based team care for the life of the transplant, not just for the first 3 months where it's paid for, not for the first year, for the first 5 years, for the first 10 years, for the 15 years and 20 years. It's important because what it requires is a village of people, not just the nephrologists, the dietitians, the social workers, the front office people to to collect data, submit it to UNOS. All of it goes, communicate to the referring nephrologist. It requires resources, which we don't have because they're not funded for. It requires people to be trained for. I just wanted to show a small little graph to show how we are reimbursed as post-transplant nephrologists. We all are slaves to what we call RVU. That's how they judge us, how much we work, and can I earn my salary? Do I still have a job? So if you look at it, 30 to 40% of my time is non-billable work. What I do for my patients cannot be billed for. There is no RVU billing for that. That's what I do. I do it very gladly. But my masters say, generate the RVU, okay? So there has to be a way we change it. And look at the complexity, look at how much RVU. It is $55 for a transplant nephrologist. An oncologist who also deals with complex patients is $75 to $85. An immunologist is more than $100. So it is something which we need. It has to be overhauled because unless you invest in your providers, you're going to run out of transplant nephrologists. We have a fellowship program asked by nephrology fellows, what do you want to become when you graduate? We want to do dialysis. We want to go to a clinic. How many of you want to go to a transplant fellowship? And they look at me, oh, it's very interesting. It's great. I love my patients, but they don't want to go to it. So we have to look to the future. We have to incentivize this as well. Now, that's where I have to ask my friends in CMS, right? So we need improved transplant outcomes. We have these programs to align with the objectives. We have to improve the RVU, the way the RVU payment models need to change. We have to look at long-term survival. All along, I've been talking about 1 year. I started my fellowship long years. It was 1 year graft survival UNOS. Then after a long fight, it became 3 years, guys. We're talking about 3 years. We need to look at not 3, 5, 10, 15, 20. That's the life of a transplant patient. So we need to look at matrices which are different. Like we said, we need to look at things like not just survival, the quality of life, the side effects of the medication, adherence. Is there any matrix which looks at medication adherence? None. I'll guarantee you this. Okay, there is none. I've been doing this for 30 years. You don't have that. So we have to look at it in a different way. And all the stakeholders, we need to be aligned in thought. It's just not us. It is not AAKP alone. It's people in Congress. It's people in CMS, FDA. We all have to buy in together. So that's closing the gap. We are so glad that we have long-term immunosuppression coverage, but that is not enough. I still have patients falling through the gap. Every month I have at least one. Why? Patients don't know how to fill the forms. They don't understand it. So there has to be patient education. Not just that. I always tell my patients, a healthy kidney can be only in a healthy patient. You fund the immunosuppression, what about his diabetes and high blood pressure? So he doesn't have money for that. He can't buy it. So his creatinine is okay, but it comes with high blood pressure, blood sugars through the roof. So we need to have a holistic approach to healthcare, not part by part. We just can't have heart, kidney. You got to look at things together. So that's my thing, that we need to start looking at holistically patients. We have to look at both short-term and long-term. We have to invest in both pre-transplant, pre-allocation, as well as post-transplant. We improve the number of transplants by increasing living donation, decreasing discard rates, making more sensible matrices for judging us, but also for long-term graft survival. And that's my final slide. It's a village. In a post-transplant clinic, it takes a village to take care of a patient. So in the transplant community at large, we need everybody. We need the patient's help to advocate for us. We need the Congress. We need administration. We need FDA, CMS. Everybody needs to work towards this common goal, which is patient-centered care should be the standard, not the exception. It's just not a talking point. It has to happen. Your reform needs to be driven by equity, accountability, and innovation. Research, you need to target at long-term outcomes as well. You need to have a collaborative care. You need to talk. And this coordinated care, it takes an effort. And what is the dream? The dream is 1 kidney in a lifetime for a patient. Can you achieve it in the next 10 years, next 5 years? I think if you're ambitious, we can. It's a dream, but let's go ahead. Let's work together. Let's achieve it. Thank you.
Thank you very much, Dr. Jagadeesan. And this session was actually about challenging the status quo in order to advance kidney health. So think about it. We live in an era of what's called common sense medicine, and we're advancing the efforts to expand patient-centered medicine. You heard from Dr. Nguyen, who's challenging the precepts of Medicare Advantage and what does it mean for patients. You heard from Dr. Ashfaq talking about what is ideal care and patient access to that, and what are the clinical guidelines that exist now that simply do not anticipate innovation and the best outcomes for patients, and how do we change that? And last, you heard Dr. Jagadeesan talking about the fact that America's policy is greater transplantation, but who's looking out for the long-term interests of that transplant patient? Or do they just disappear into the ether and come back and demand second and third transplants? What's preventable? These 3 minds are so welcome at AAKP because we're challenging the status quo and we're trying to bring healthcare back to the patient and keep things centered. Our president, Ed Hickey, who you'll hear from in a minute here as he wraps up our event today, often says our mission is pure. It's anchored on the patients. And we hope on this panel you understand clearly that some of the brightest minds haven't forgotten the patient and been lost in the system. They're actually advocating for the person who comes in their office and says, I'm a patient and I want to live longer.